My name is Mary Alice Anacarico, Senior Vice President and System Chief Information Officer for Henry Ford Health System. I'd like to introduce to you the rationale around our implementation effort of EPIC at Henry Ford Health System and introduce to you some of the planned and achievable outcomes that will be illustrated as members of our team have further discussion with you. Henry Ford established a uniquely integrated health system model in 1915. It's the fourth largest employer in the Metro Detroit area with 29,000 employees, 5 hospitals, over 70 ambulatory facilities that include home health, retail, community care services, a large employed medical staff, and an integrated insurance plan. The revenues for Henry Ford Health System exceed $6 billion. The system facilities include a large academic hospital, Henry Ford Hospital, with 877 beds. There are 4 community hospitals that include an additional 1,528 beds that are comprised of Macomb, Clinton Township, Wyandotte, West Bloomfield, and Allegiance Health. The system also includes 3 behavioral health facilities, as well as greater than 75 sites, including our medical centers, outpatient surgery, urgent care, and emergency services. The Henry Ford Medical Group includes 1,200 members of our employed practices, as well as an equal number of affiliated non-employed physicians.
I'm Dr. Michelle Schreiber. I'm the Chief Quality Officer of the Henry Ford Health System, and I was the lead physician for the implementation of our EPIC electronic medical record in a project called HELIOS, Henry Ford's Electronic Integrated Information System. One of the key principles of our EPIC implementation was to leverage the electronic medical record to improve patient engagement, quality, and safety. Our Board of Trustees, Our Board of Trustees supervising our HELIOS project placed these as priorities number 1 and 2. And indeed, using the electronic medical record is a key strategy in improving quality and safety. We do this through a cycle of improvement that includes, first, standardized event data input, including workflow to achieve that input, always looking for data that can be queried. Second, development of analytic capabilities to aggregate data, segment it, look at populations, and provide feedback down to the individual level. Third, clinical decision support electronically that provides information at the right time to foster correct actions. And then, using these leads to inform clinical and operational decision-making and drive ongoing continued performance improvement in a cyclical fashion, always making our targets better. Henry Ford Health System has a long history of quality and excellence, including having won the Henry Ford Health System has a long history of quality and excellence, including having won the Malcolm Baldrige Award. Yet, like every other organization, we have an opportunity to continue to improve our quality metrics, especially as we go down our high reliability journey and target 0 harm. We've leveraged the electronic medical record to do many quality initiatives, including patient engagement through MyChart, reducing sepsis, improving behavioral health, using a translator navigator to make sure that all of our patients have access to translator services, and advanced care planning. Today we want to share with you 2 examples of how we use the electronic medical record to improve quality and safety. The first will be catheter-associated urinary tract reductions, and the second will be venous thromboembolism reductions. Why did we choose a project around catheter-associated urinary tract infections, also known as CAUTI? First, this is a key outcome for CMS value-based purchasing and counts in the hospital-acquired conditions as well as the overall STARS rating. But more importantly, it's a leading cause of avoidable hospital morbidity. The clinical documentation is rich with information that up until now hadn't been well used or leveraged. We found that it is possible to automate the NHSN rules. In other words, the database from the Centers for Disease Control to which all of our hospitals report their infectious data. Our initial performance in this database was very high around catheter-associated UTIs, and we needed more timely information for improvement. Our intended outcomes were first to improve the CAUTI measurement by creating a timely, accurate measure and dashboards that can track CAUTI trends and pinpoint areas for improvement. Next, we improved urine culturing and catheter removal by providing feedback on urine culture rates by unit and improving flow sheets to look at documentation and improve. The next step was improving the reliability of care. Here we worked with nurses to remove catheters that are not needed. We provided daily feedback on the outcome for infection control, and we shared these at daily hospital safety huddles. And finally, we educated nurses and residents on the NHSN definitions and the problems with automatically pan-culturing. The last intended outcome, obviously, was to improve our outcome. And here we were looking at reducing instances of catheter-associated urinary tract infections in the hospital and save patients' lives and improve quality of life for them. The key elements of the project included the following. We removed an ineffective alert for providers to order Foley catheters to be taken out. We provided decision support for nurses to remove Foley catheters. We created a daily task on the nurse and nurses' aides work list to provide catheter hygiene and perineal hygiene. We developed policies in the hospital for nurse-driven protocols for catheter removal, as well as automatic tracking of CAUTIs and cultures using the national guidelines. As I described before, we had educational rollout to nurses, nurse assistants, and providers, and we implemented other evidence-based practices related to catheter insertion and catheter maintenance. Finally, accountability was built across the system through huddles, reports, and dashboards. This is an example of triggering the best practice advisory or decision support. We created a BPA that fired within 24 hours after urinary catheter replacement, with the goal to facilitate nurse-driven catheter removal. The nurse will evaluate the defined criteria to determine if the catheter should be removed or remain in place, and they have to pick a reason. On the nursing care work list task, each individual nurse is assigned the tasks that are important in terms of not only removing Foleys, but other tasks that are necessary for the daily care of patients. This is a reminder then to the individual nurse to remove the Foley when it's appropriate to do so. Accountability was built across the system in multiple teams and multiple ways of providing data feedback. We had a health system catheter-associated UTI team. In other words, hospitals across our entire organization came together to work on this in a standardized, systematic way. In addition, we had hospital-specific catheter-associated UTI teams. Multidisciplinary rounds were conducted to ensure that we had the best education and training, and the inpatient departments individually received reports on how they were performing around CAUTI. In our hospitals, we have daily safety huddles as part of our high reliability journey that ensures that operations knows what is going on all of the time. These are multidisciplinary, and during those, we have report outs on infection control, including catheter-associated urinary tract infection. And finally, we created health system dashboards, which go across our entire organization and are reviewed at our System Quality Forum as well as our Board of Trustees. The CAUTI reporting comes from our flow sheet rows for Foley catheters, as well as our temperature, culture results, and these capture all the variables that we need for the logic of the reporting. The CAUTI denominators for the NHSN were built very early, right after go live. We co-developed numerator tracking with our IT team, analytics, infection control, as well as clinicians. We redesigned our workflows and our flow sheets based on guidelines and nursing feedback and tracked urine culture rates as well as positive cultures. This is an example of a hospital department report tracking CAUTIs for the entire hospital, and you can note that you can drill down to any specific unit in the hospital to see how they are performing. Fortunately, having started at a relatively high level, you can see we have many months of 0 CAUTI. The hospital daily safety report out on infections that occurs during the daily safety huddle looks like this, where we have quality metrics and significant events, and we report those out by floor. This makes it transparent and visible to action for all. And finally, our system quality dashboard, which shows tracking of CAUTIs as well as other important infections, is important in transmitting this information across the entire organization, as well as to our Board of Trustees. We actually follow a STEEP format for our quality dashboards. In other words, those Institute of Medicine principles of quality: safe, timely, effective, efficient, equitable, and patient-centered. CAUTI is one of our SAFE metrics. We do follow the NHSN logic for automatic tracking, and we developed an automated measurement model for current clinical documentation. We list recent cases, and those are sent every morning for review. Thus, people have immediate feedback as to their performance. We have the ability for local deep dive and review processes, as well as the tracking of urine culture rates and catheter days on the dashboard. There's a daily list of patients who have catheters in place that are provided to all nursing units, so every day the nurse manager and the individual nurses can review who has a Foley in and are they eligible to have that removed. Here's an example of the reporting that we have done. We've developed dashboards that show utilization and infection with drill down to the unit, a daily email of case-specific data to hospital leaders, and a large data mart in our electronic data warehouse with every patient with catheter and positive blood culture. Again, you can see over time our improved performance, not only in ensuring that our urine culture rate is appropriate following the Choosing Wisely guidelines, but our CAUTI rate has also significantly declined over time. This was actually a key feature of reducing urinary tract infections, was to ensure that we were doing appropriate urine cultures and not just ordering urine cultures when they weren't indicated. The risks of pan-culturing were provided in education to residents and to nurses, and catheter removal was something that was highly emphasized. Our analysis showed a very high rate of culturing, and infection control found that many events met the NHSN definition with unrelated fever and just colonization. So our dashboards continuously monitor culture rates and catheter utilization, which you can see here have fallen dramatically over time. What are our outcomes? The estimated cost of a CAUTI in our hospital, and this is specific to our data, is approximately $8,000 of additional cost. The decrease that we had is equivalent to about 80 fewer CAUTIs per year, which translates into a $640,000 in direct savings annually. This is very important for the organization, but most importantly, it means that patients did not have Foleys or did not have cultures when they didn't need them. I should also comment that we experimented with different kinds of devices to use rather than Foleys. So different devices for women as well as men. Our outcomes overall and our trends you can see here have been quite remarkable. On many of our floors, we have virtually eliminated catheter-associated urinary tract infections, and we've had remarkable success, so we are now better than national standards. I turn the conversation now to the improvements that we have made in venous thromboembolism.
My name is Jack Jordan. I'm currently the Director of Performance Excellence and Quality at Henry Ford Hospital. During a lot of this work, I was the Director of Clinical Analytics at Henry Ford Health System. I'm here today to talk to you about our work on venous thromboembolism at Henry Ford Health System. Why did we choose to focus on VTE work? It's a key hospital outcome for CMS and value-based purchasing. It's also a leading cause of sudden death in hospitals. Clinical documentation has a large amount of rich information that hasn't been historically well used to work on VTEs. There's a balance between bleeding and getting a clot in the hospital as well. It's burdensome for clinical documentation, asking for custom risk assessments from providers. Currently, we have performance issues on the PSI 12, as do many academic health centers. But also, PSI 12 that the federal government has excludes medical patients, and we had a large interest in working on VTE in our medical patients as well. There's also a time for far more timely data related to this to help people cycle through improvements much faster. One of the great advantages we had in our implementation of our electronic medical record is that we have problem-oriented charting. And from the analytics, this was in many ways a dream because it enabled us to track problems in the hospital real time of what's going on. And that was leveraged in some of the things we did here you'll see later. VT is also a test of our real-time scoring capabilities in our EMR that you'll hear a little bit more about as well. We co-developed this with a team that involved people from information technology, analytics, and clinicians. The background data mart that we built to this in near real-time data is also, I think, one of the outstanding kind of benchmark products that have come out of this as well. And we redesigned our order sets based on guidelines and physician feedback, and we tracked missed doses, refused doses, and used that as a leverage for working on improving the outcomes of our patients. So the cascade of how this worked was that we wanted to create timely, accurate VTE measurement for inpatients, both medical and surgical, and put dashboards around them so that we could be trending and pinpoint areas for improvement. To do that, we designed and integrated an effective risk assessment model in our EHR and automated our VTE risk assessment, taking the burden from physicians of having to score each and every patient. After we did that, we facilitated VTE prevention through developing prophylaxis order sets, visual aids, developed decision support tools, best practice alerts, and guidelines for compliance. This helped us get insights into our process where we could reduce instances of blood clots and pulmonary embolisms in the hospital and save patients' lives. A couple different things we did in the VTE project. First, we updated order sets with mandatory fields. The decision support alerts for providers for any new admission greater than 6 hours that did not have mechanical or pharmacological treatment was ordered. And decision support for providers actions based on the risk scale, which we chose PADOA. The creation of a patient list with PADOA scores in pilot departments, and daily reports to key providers, as well as the VTE dashboards. The decision support that we built first for prophylaxis orders on admission was a best practice alert. It fires 6 hours into the stay for any admission if it hasn't already been ordered. You can see on the screen what our order looks like when it pops up. The goal for this is to facilitate reliable pharmacological and mechanical prophylaxis or understanding a rationale for not prescribing it. The other thing that we had is the ability to look at the PADOA scores in the hospital for any patient that you wanted that's updated on a minute-by-minute basis so you can see the high-risk patients. This was more used for a lot of the work the team was doing than the actual clinicians, but this same data gets used for clinicians in a little bit different structure. One of the other exciting parts of this project when VTE work was developing of a near real-time measurement model. This measurement model was developed using both the problem list and the medication administration. This was chosen as one of the 2016 winners from the National Quality Forum's Measure Incubator Innovation Challenge. It was the only one of the 5 winners that was developed by a delivery system. It has much better sensitivity than the PSI-12 measure and comparable specificity. We can measure DVT rate for both medical and surgical patients with equal reliability. It's done in near real time, running each night and available the next morning for the DVTs that happened the day before. So we have this ability to report this out on dashboards and show this as well as other factors that are there. We deliver to the patients in the chart availability of lots of variables for them to work through. We built a data mart that currently has over 280,000 patients in it and shows our reliability at VTE prophylaxis and treatment. The dashboards look for missed and refused doses. And we send out emails of specific cases to physicians and other leaders in the hospital on a daily basis to review cases in near real time. For the caregivers in the hospital, we built ability to see their patient list and throw onto there who is at risk with the Padua score, as you can see the red and green little balls there, and then what prophylaxis they're receiving. And in this case, we had the top patient has no prophylaxis even though they're high risk, but off to the side you can see their problem list shows that this patient currently has a bleed, so that in just an instant the caregiver can actually see why or why not they don't have care. On the bottom we have a patient that's green and they're actually receiving prophylaxis, but again, if you look over at their problem list, this patient has a stroke and it's warranted that they would be receiving those drugs as well. This gives the ability to be very reliable and quickly seeing and making judgment calls for the caregivers in their patient list for their patient care every day. How did this all play out in results? Well, by working on missed and refused prophylaxis and education to patients, we did some statistical analysis and found a clear relationship between missing prophylaxis and the risk of getting a clot. So we focused on patient and nurse education, developed materials for patients to help them understand the importance of accepting prophylaxis. We track this on dashboards to continually monitor our prophylaxis and refusals. And below you can see 3 different charts from our Henry Ford West Bloomfield Hospital. One showing a dramatic drop in the number of patients that refuse doses from around 15% to 5% refusals. You can see prophylaxis of missed doses dropping from 25 to 11%, and in that you can see the quarterly number of DVTs happening in the hospital dropping from 50 to around 20 a quarter. A very dramatic improvement at one hospital. This has been done at the other hospitals in our health system as well. Here's the overall trend in the VTEs per 1,000 patient days in our health system with a timeline of the different work that went on. So the development of the new measurement model started very early on back in 2014. We added the analytics to track missed and refused doses later on, late in 2014. Henry Ford West Bloomfield Hospital took the lead on working with this data in their hospital early on in 2015. The Padua tool was added later in early 2016, and the risk assessment available to that. And as you can see in this, that the trend of our rates for the entire health system dropped from about 2 per 1,000 patient days to about 1.3, a fairly dramatic drop in the number of venous thromboembolism cases in our system each month. So, what does this all add up to? Well, when you consider that 30% mortality for patients within 30 days that have a VTE in the hospital, and of those that survive, roughly 20% of them experience lifelong complications. According to AHRQ in 2013, around $8,000 is the additional cost to treat a VTE in the hospital, and around $14,000 to $17,000 in additional cost to a health plan or insurance company covering it. So with the work we did at Henry Ford Health System, we decreased the equivalent of 180 less instances of VTE per year. That's equivalent to roughly saving 54 lives, $1.4 million in direct costs to the health system, as well as up to $3 million in saving for the health system and insurers as well. So this had a huge impact on our patients as well as the finances for our health system.